Welcome to the webinar, Adapting to Philips Respironics Sleep and Respiratory Product Portfolio Changes, a live panel discussion presented by the American Academy of Sleep Medicine. I am Mohammad Adil Rishi, and I convey my thanks to all of you for joining us today. We are honored to have representation from various societies contributing to our expert panel. While the scarcity of information may pose challenges in finding definitive answers to some of the questions today, our esteemed panelists will offer their valuable insights on navigating this ongoing issue. Any unanswered questions can also be forwarded to us via email at recall@asm.org. Please note that this session is being recorded and will later be available on the Academy's website. I'd like to remind you all that your audio is muted and your video is off. I encourage you to include any questions on this topic for any speaker in the Q&A app of the Zoom platform. Without further ado, I would like to introduce our moderator, Dr. Shannon Sullivan, a clinical professor at the Stanford University School of Medicine. Welcome, Dr. Sullivan.
Thank you, Adil, and thank you to everyone. I just am going to very quickly introduce our panelists. We're very, very fortunate today to have a number of different member societies who are coming together to talk about the issues today. These include Adil Rishi and Andrew Naiman from the American Academy of Sleep Medicine, as well as Amanda Leitner and Jessica Schweller from AARC. We have Dr. Anissa Das from CHEST, Karin Johnson, as well as Margaret K. Stacey from AAN, and Vaishnavi Kundal from ATS, as well as Sarah Brennicke from AAST. So welcome to you all, and I really look forward to our conversation today. I thought I'd start by presenting a little background that is sort of underpinning why we're getting together at this moment in time. So if we can advance to the next slide, please. This is not unfamiliar territory for many of the folks on this call, and maybe also some of our other participants. But back on January 25th of this year, Philips Respironics announced that it will stop selling 19 different sleep and respiratory products. Now, the sales of some of these devices that were impacted by the 2021 recall have been on hold since that time, but this provides a little more context going forward. Philips Respironics also noted that in the United States and in U.S. territories, they will focus on the sale of consumables and accessories, including masks, and will not return to the sale of hospital ventilation products, certain home ventilation products, portable and stationary oxygen concentrators, and sleep diagnostic products. They also note that customers will be contacted directly regarding any order cancellations resulting from our portfolio changes. And these aren't necessarily customers with respect to patients, but actually sleep labs and practices. So our next slide actually shows the affected devices, and I want to pay. There's a lot on here. It's a busy slide, but I wanted to pay particular attention to number one, the discontinuation date for sales, which is that middle column. And then also the end of service date, which you can see in every case is a date some years after the sales discontinuation date. And it's important to see here also that there's a variety of sales discontinuation dates. So for example, the cough assist device, as well as Alice, PDX announcements were made late last year. You may remember those. But so the end of service date is also a step function different in terms of when that will end. Next slide. Now, I want to point out the situation is evolving. It has been reported that Philips has agreed to halt U.S. sales until it meets the terms of a consent decree from FDA. And if that's unfamiliar terminology, a consent decree is essentially an agreement between FDA and a company, typically which might be issued after violations of regulatory requirements. It can be thought of as a legally binding performance improvement plan, and it is court enforced. It is a settlement which the court will review, and all parties must agree to it, and that agreement needs to be approved by a court. So it has been reported that this consent decree is in process and close to finalization, and it will be submitted to a U.S. court for approval. But I want to point out here that it has not been finalized. When that does happen in the future, the consent decree is expected to outline a roadmap of what actions and milestones Philips Respironics should meet in order to demonstrate regulatory compliance and to restore future business. And if you've been reading coverage of this, you may see that also the U.S. Department of Justice is involved, and they have a role in negotiating as a representative of the FDA. And next slide. And so some additional, I do encourage everybody on this call, if you haven't already, to visit the Philips website. I have the link there at the bottom to just review this update. But a couple of terms I thought are useful. One is, what's the definition of end of service? So from the Philips website, once a product is discontinued for sale, then the manufacturer will provide a specified number of years of service support, wherein all relevant repair parts, accessories, et cetera, can be serviced, and that would be pending part availability. And then they also have in their FAQs, I thought this was an interesting one, if you have a product that's discontinued and then it fails within the warranty period and is unable to be repaired, Philips will provide refunds as articulated in the warranty terms, but may not be able to provide a replacement product. And again, this language is coming from the Philips website. Next slide. And so I thought, with respect to starting off a conversation, there's lots of questions, I think lots of interesting territory for us to cover. But where we might get started with our panelists today is to talk about what the Philips announcement means for sleep laboratories and sleep practices, and what are the sorts of issues that you all are thinking about or encountering. And I thought what we would do, although I'd love to hear from as many panelists as possible, is maybe have the lead on that particular question go to Dr. Rishi and Dr. Naiman for some thoughts.
Thank you, Shannon, and thank you, ASM, for the invitation. Adele and I were talking about this earlier. Some of the things that come to mind are essentially the cost of care, like with the use, also transitioning out is the Omni Lab, specifically for sleep labs. That's the titration module that we use. And so when you're transitioning from that device to an alternative, the cost in getting the interface cables, their accessories, those kinds of things is kind of incumbent on the lab to, take over and try to provide a healthy alternative for our patients. The other thing is of course, teaching our technicians new techniques and different titration modules. So that too is important, and they're becoming facile with that technology difference so that successful titrations are, of course, accomplished meaningfully. So all those things are in the underpinning in the background in the sleep lab, both with learning new aspects to titrations, including tidal volume assessment, ideal body weight, things that they hadn't had to think about before, becoming more nuanced in this new era. I think also too, creating some protocols and policies that are required for labs when we are making these transitions is also key. And then finally, what on the patient side from a sleep lab is, losing some of their confidence with one form of product is, am I going to have the same problem later with a newer product or a device? Is it going to feel the same? I like my old device. I really don't want to make that transition. And then insurance barriers if they really insist on getting a new device. So these things have been brought up before, kind of making their way even brought to the forefront with this announcement. So I think how we kind of tackle those issues, as a community is very important. And then what are some new prescription alternatives that will provide our patients some confidence? And Adil, any other thoughts, from my standpoint? I think those were my major concerns raised.
Yeah, thank you, Andrew. I would echo your concerns. I think a couple of additional points. One, so for small practices, the type of capital involved to get new devices for their labs can be prohibitive. On the, Indiana University, where I'm located, is a very large practice. And so we have, I think, 65 OmniLab devices in our practice statewide. The replacement cost, you can imagine is very large. There are obviously other devices as well that are going out of service and will require replacement. So replacing all the devices or even the course of time that we have during the life of service, can be in millions of dollars for many institutions. So it's not very easy. In addition, so we know that Omni Labs have been recalled devices, and Philips, when they started the repair and replace process a couple of years ago, focused on the patient devices, but OmniLab devices repair and replace process, just recently was starting to pick up. So I think continuing to do studies with these devices as well is problematic. So I think eventually you'd have to do something about it, but I think I agree with you that the cost, both in terms of personnel as well as in money, I think is going to be prohibitive for a lot of people.
And thank you so much, Andrew and Adil. And I want to pick up on that thread around, in particular, sort of this transition from thinking about specific recalled types of devices to our long-term coordination of care and planning, and what this really means for the patient experience as they maybe go from more acute care settings into the outpatient space. And so with that, I'd like to think a little bit about broadly respiratory care provision, coordination of care, what this means for coordinating with medical equipment providers in sleep, but also, again, that's a long list of devices that were included in that January announcement. So maybe Dr. Anissa Das and Sarah Brennicke could help us to think through some of the issues that they might be seeing or facing. And I also wanted to add, Dr. Lisa Wolf has joined us on the panel. Thank you so much, Dr. Wolf, for joining us today. And we may be phoning a friend a little bit later. So thank you so much.
Thank you. I'll start because ironically, I was on a call with our DME earlier today and having this exact conversation. About the fact that everyone had sort of shifted towards the Trilogy EVO and the Astral when the 100s and 200s went away, and so my conversation was just where are we going now that we know that there's less players out there, and they had said, well, we're going to have our conversation and then we're going to let you know. And I said, whoa, this is an opportunity to actually collaborate and have us not all be talking about different groups, right? Like before you make this decision as a DME, because it's the DME that we work with regularly within our institution. Now, maybe let's take this as a positive opportunity in ways that we can collaborate moving forward, right? And have the systems that we're using as an inpatient center collaborating and having conversations with those of us who do outpatient longitudinal care and the devices that we want the patients to be on and that they're going to be on, and the devices that the DMEs are going to be carrying, having conversations about that and having there be some continuity. There, I think that's one piece, is that there's a potential for opportunity since we're sort of starting from scratch now. So that's piece one. The other issue is, lots of folks have these V30s and V60s that have been recalled that we're still using. We've gotten pretty good at the lab. So our particular lab has half the OmniLab system and half ResMed. So we've been able to just use the ResMed systems. But not a lot of centers had that opportunity and are still using the recalled devices. But I feel like in the outpatient world, we've been pretty good about signing releases and disclosing that information. That's not necessarily happening on the inpatient side with these non-invasive ventilators, and it may be at some institutions, but certainly not widespread. So that's another conversation. And those machines that are now recalled and are being serviced are only being serviced for 5 years. So you mentioned this, and we talked about this a little bit earlier. In the next 5 years, there's going to be a need that's exorbitantly higher than we've ever seen before, right? So we need to be thinking very proactively about how we're going to account for this so that we don't have a huge markup in prices because there's limited availability, and that we're thinking now that we have 5 years, we need to be having this conversation with our vendors and maybe improving conversations with the manufacturers now, right? And being advocates for our patients at this point. I'll stop there. I have other things to say, but I'll stop there.
Thank you. So I manage a sleep center for a large healthcare organization, one of 5 of our sleep centers, and durable medical equipment within the healthcare organization. And we've experienced, obviously, as everybody on the call, a big impact with this, but really starting with COVID. Because, then it turned into supply chain issues. So not being able to, get our patients the devices that were needed. So one of the big lessons that we learned here was don't put all your eggs into one basket, and really have these conversations like we're having today, communicating with the physicians, because a lot of pressure has been put onto the physicians during this time period. My clinical sleep educators have been taking it one patient at a time when they're getting the phone calls coming in, and really just trying to make sure that our communication is good. On the sleep side, we did have to pivot and look into a different home study device. And again, just getting that education and remaining consistent amongst the whole health system so that we can best care for our patients.
Thank you so much. I think, these are very thoughtful comments. And one of the things that strikes me as I listen to it is sort of resource limitation across the board. On the one hand, you're having to contemplate which device, when. On the other hand, there are resource limitations more broadly felt, and that includes, you mentioned Sarah, physician, but the entire teams of folks across the boards who are serving these patients also are taking extra time, thinking through how to best transition their patients when needed, transition their practice, looking for that financing to be able to transition provision with respect to certain devices as well. So I think there are sort of a number of different layers with respect to resource limitation. And from there, I'd like to even open the question even more on the next slide, since this is an ambitious conversation. How is this affecting, or what does this mean for patients who might be dependent upon devices from Philips Respironics at home? Now, with our sleep app, we might be thinking about hats, we might be thinking about positive airway pressure devices, respiratory assist devices. But again, keeping in mind that there is a menu, a pretty broad menu of different devices that have been impacted by the January announcement, and announcement in the case of, for example, cough assist, announcements made last fall. What does this mean for patients? I would love to hear sort of what you're hearing from patients, what their concerns are, what they're worried about. We heard earlier about loss of faith, and I'm wondering more pragmatically, just for listeners on this call, how do we help patients navigate this from their perspective? And I thought maybe Vaishnavi, Amanda, Jessica, also Lisa, maybe might be able to weigh in on some of these aspects. Anyone on the call, though, is also welcome to jump in.
Thanks, Shannon. So yeah, I think, somebody brought this up earlier, but really, I think the first thing is the patients feeling comfortable transitioning to a new device as compared to a device that they've been using for so long. Maybe, if they've been titrated on one device or using one device and switching to another device or another company, they're going to be uncomfortable. Maybe, there's going to be hassles in it working different ways. And so that's certainly one big aspect of the patients kind of adapting to this change. But I think one of the points that was brought up earlier was I think the bottleneck, maybe at least in our institution, we're not seeing it at the moment because our DMEs, I was talking to our DME provider today, and our DME is actually kind of a lot of the small DMEs have been bought out by a larger company so that they're able to acquire a lot of devices in bulk, such as ResMed devices. So, I think given that, we haven't really seen the effect as yet, but I think the bottleneck really we're going to start seeing later on as, the replacement devices are no longer going to be available. I think you showed in that slide around 2029. So I think maybe what we really need to do is talk to our DMEs and start planning for the bottleneck that we're going to be seeing in the next few years, learning maybe from some of the lessons that, from 2 years ago when we had the Philips recall. So I think that's really kind of what I heard from our DME provider. But yeah, I'm interested to hear what, others have experienced.
I'll kind of chime in next. I feel like a lot of the financial situations that we're dealing with our patients, obviously we talked a little bit about the faith in the company and those who wanted to transition care to different materials. Financially, it's not feasible for a lot of them. Plus, if we have patients who are getting that transition to a different device, if their insurance doesn't pay for new equipment like different hoses and filters and water chambers and things like that that are going to be fitting to that machine, the patients may be stuck kind of without the supplies. I know many of our patients ended up, when they got their replacements from Philips, with just a CPAP device, no hose, filters, no water chambers, no humidifiers, and were kind of left to fend for themselves. And so I think that kind of left a bad taste in a lot of patients' mouths. We see a lot of our DME companies who kind of negotiate prices for certain materials and certain equipment from manufacturers. And I'm just concerned about some of these other devices like nebulizers and cough assists, if they don't have the kind of the backlog of some of these pieces of equipment. How long is it going to take for our patients to get replacements when they need to, if something breaks? We've been seeing a lot of our patients telling us already, some DME companies are telling them they're not servicing a Philips device any longer. So if something's broke, they're kind of stuck with having to either call Philips or try to figure out a different DME company that will service the machine. So I think that there's a lot of patient, despair is what I'm kind of seeing. A lot of just kind of, concerns about what's next. We had one recall to several other issues that are kind of coming down the pipeline. And I guess they really want to make sure that they're going to have the service that they need for their equipment, because I know a lot of my patients can't sleep without a CPAP machine. And so knowing that if one night something breaks and they don't have that backup, they really want to know what's going to come next.
Shannon?
Dr. Lisa Wolf.
Yeah, so I just wanted to add one thing real quick. There's a lot of people who are concerned about lack of access to an alternative for an in-lab machine and lack of access to equipment, because exactly what Anissa just said, the numbers of devices necessary are huge. We have today representatives from all of our major agencies, all of our major advocates for sleep as a group. One of the things that we need to think about pushing for is saying to the FDA, look, this is a national crisis. We can't put ourselves in the position where we have one vendor for this stuff. What we need to say is that there are other vendors, mostly European vendors, some of them are Japanese, that have alternative devices. They should be able to come in, get 510K, and then clearance for sale in the US without having to do all new studies, right? The cost is tremendous. The time is tremendous to do that. They should be able to use predicate devices that are already been approved, studies that were done abroad and already approved, and then get newer devices on the US market. And that is something that we as a group can stand up for and try to get legislated.
I think that's an excellent point. And as we go through this conversation, Lisa and others, I'm right. When you see me taking my eyes off the screen, it's because I'm making a list of ideas and how do we get together and think about how to unify our voices to really represent our practices, our patients, and really sort of affect change. Amanda, and anything you would add to those points or different perspectives on some of these points of view?
I think just to echo what the panel has already kind of said, to keep it really simple, it's going to be really important for these patients who are dependent on these devices to really educate them. And I think they just released that the literacy rate right now is at a 5th grade reading level. So even if they did go onto the Philips website and kind of started looking things up if they are on these devices. Sometimes I think it might be difficult for them to be able to read that material if they're not medical. So I think education is going to play a big component in educating them, as well as educating, all of us as medical providers too, on what their options are that will treat them to the best of our ability.
That's an excellent point, and that does remind me a little bit of where we found ourselves in the early days of the recall, where one of the positions we were finding ourselves in was having to explain the announcement and also be able to say, and we don't really know how things are going to evolve because the situation is evolving and we're still planning and trying to figure out how to best transition our patients and transition our practices. I think that also has implications. It's a little bit harder to sort of explain when you don't have your game plan fully set up. I think also this issue of patient faith and patient concern that they won't have the product they need when they need it. These are also issues to hold in balance. And then another, Anissa Das, do you want to, I think you made an additional point. I'm not sure our webinar participants can see your comment. I think this is a really important one about disparity.
Yeah, I added it on as an answer to somebody because I realized they couldn't. So the other concern that really hasn't been brought to light is, with the limitation of in-lab titrations, and this I have seen absolutely in our clinic, we can pivot to AutoPAP for a lot of patients, right? We have that option. That is not an option for patients on Medicaid. So Medicaid patients, not only do they need a diagnostic, but if they don't happen to get split, they have to get back in line to wait for now one of your beds that happens to have a titration device in it, right? So I think there's a greater disparity of care in that area that's growing with the Medicaid population because of these limitations.
If I can add to that, one thing that may or may not be true, and I would definitely push you to follow up in your state, in Massachusetts, after many years of that rule, we pushed back, and for the initially they let us add to our recommendations in-lab titration if insurance insists. And if we put that language in, they let us not do the titration. And so for the last 5 years or more, we've been able to get Medicaid people on without a titration. The other thing I want to mention is the ASM advocacy committee did write a letter. There is a sort of bill before Congress to try to improve FDA's response to issues like the recall. And so we did write a letter sort of highlighting what were all the many issues that we're highlighting today that came up and what we would expect from a better FDA response. Not only things like better instructions of what to do and what the options are, but also, how do we help with these insurance gaps in care and in making sure that people aren't falling in the cracks where, if they can't get a supply or they can't get something that, that it is covered early for, by their insurances and other, issues like that. So I don't know if other societies have also done any of these letters as part of their advocacy groups, but I think that can, hopefully lead to some more federal changes demanding a better system next time, that hopefully this doesn't happen.
Well, thank you, Karen. Sorry to interrupt. I wanted to, I think these themes tie together really nicely because when we think, like Lisa brought up, about advocacy, we have all of our member groups here and thinking about predicate devices, but also what are streamlined approaches to how to be able to transition our patients to other devices so that we're not stuck in a loop of delays simply because of perhaps anachronistic insurance qualifiers, and those can vary from company to company, state to state, insurance to insurance. So excellent point. And I think someone else is going to chime in, so I apologize.
Oh, no, thank you, Shannon. I was just highlighting what Anissa said because the ASM conducted that survey not too long ago regarding disparities during this recall challenge. And I think this will again highlight those challenges once more, not only for devices, titrations, but also advanced devices. And I think one of the things is helping us giving us some tools that the FDA can provide to help us monitor these patients better and really close those gaps is key.
Absolutely. And continuing on this theme sort of payer-driven gaps in care, essentially, or payer-associated gaps in care. And of course, individual payers may not be prepared to account for this disruption in service provision, each and every one of them. So thinking about advocacy, would love to hear your thoughts, Karen and Meg, on interfacing with payers, but also, again, turning to the other side of the coin. What are the implications for patient populations, especially our most vulnerable patients? And what are some of the contemplations you might have had in terms of being able to help patients transition to different devices? So we've heard a little bit about this before, but again, it's two sides of the same coin. On the one hand, it's getting payer approval to be able to do what you know how to do, which is how to help these patients. And on the other hand, how to make sure that patients are remaining at the center of their own care and able to make that transition successfully.
Yeah, I mean, I think this is going to be a frustrating process, as we've already sort of seen when we kind of went through the recall and the pandemic, from the get-go, where we had people that maybe were trying to get a new device. And obviously took Philips a very long time to replace devices. And so some people wanted to opt to get, machine on their own or to try to qualify for a new device, and it varies insurance to insurance, right? It would be great if we could actually have more consistency across, Medicare, Medicaid, and then commercial insurance, so that the rules were kind of similar instead of having to try to figure it out as we go. And I think a lot of what we ran into is patients perhaps wanting to pay for things out of pocket, but these are expensive. And that obviously brings up the disparity, right? That for some patients that wasn't an option. And so they just had to wait, till they got the machine. And then to the point of the medical literacy, I feel like a lot of patients didn't understand what they needed to do on the Philips side. So I think we are going to be doing a lot of education surrounding this, and also reassuring patients that don't have these machines that are affected, that they're not affected. We had a lot of people, over time come in and they'd stopped using their ResMed devices because they thought, those were part of the recall too. So I do think, as others have said, we really are going to have to kind of come together and figure out how we're going to educate, patients across all, levels of health literacy.
Yeah, and I don't have any great solutions, but I will confer, my patients that are not English speaking, that don't have as much resources, certainly were the ones that, had the hardest time making this happen. Again, in the insurance rules, if people took a break in care because they didn't want to use a recalled machine, now if it was long enough, they might have needed that new study, which we already talked about causes delays and issues. So, so it is certainly hard on those patients who don't have the resources or the ability to get in and sort of, help themselves. One thing I just do also want to make a point is, when we're switching between these machines, they are not the same thing. An auto CPAP is not an auto CPAP. Respironics device has a much slower protocol for increasing the pressure. ResMed is much quicker. So if you have someone on one setting, it may not give the same response. It may cause more discomfort on the other setting. So you do really need to watch that as you're transitioning devices, make sure that they're giving a good response. And it's especially problematic if you're on a more advanced machine. AVAPs from Respironics is entirely different from IVAPs. Your servo ventilators are entirely different. So if you've titrated someone on one machine, you can't just flip to quote similar settings and assume you're going to get a response. So these people often need to come in, get more studies. If you even have the right titration unit in the lab, which we talked about. And with having those right titration units, our lab has ResMed titration units, but they're 8-9 years, actually, I think they're 10 years old right now. And we have not been able, we've been asking to get new ones. They're not available. because so many other labs are needing to switch out their machines. So even the ResMed people are hitting that point of, you know, device failure and things like that, and just not having the equipment that's needed out there. So lots of issues.
Yeah, thank you so much for that, Karen and Meg. And I think many of us in our own audience are facing that same. Oh, good. And Lisa wanted to add something. Dr. Wolf.
Yeah, the other thing I was going to say is in terms of like ASM, ATS, ACCP, what Karen's bringing up is that not only are the devices different, but the settings that you have to use are different. And there's a huge education gap, because if you're used to using Respironics software that used AutoTrack to make decisions for you about triggering, cycling, inspiratory time, rise, etc., you're not going to have to do that yourself. And so we're going to need to think about being aggressive on the education side to get our physicians and respiratory therapists and RPGSTs where they need to be to use those additional settings.
And Adil.
Yeah, thank you. So one additional point is that I think Philips has said that for those devices that go out of order, that they cannot be repaired or serviced, even during this duration of time, while they're supposedly in service, that they will not replace those devices. Patient will be given, some monetary compensation. And, unfortunately, for those patients who did receive monetary compensation for their old devices when the recall initially happened, that was a minuscule amount, as we all might remember. Insurance would not cover these devices because they would say the patients are within that 5-year window. And then it comes back to the same point of, who gets left behind, those patients who can't advocate for themselves, those patients who don't have, unfortunately, I don't like to use this word, but the right type of insurance. And so I think part of what we need to advocate for is for those patients, that insurances do pick up the tab for those patients. These patients otherwise will go without treatment because the compensation that they will get for their replaced devices is not going to be enough.
Well, that's an excellent point. And Karen, I see your hand. The reflection that I wanted to make, and I wanted to also read a post that Dr. Peter gave from the Mayo posted in the Q&A section, which is that we've talked about a number of resources that we need to think about as we navigate these transitions in our practices and for our patients. One of the most important resources is time, because it's going to take time to provide education, even in our own medical environments, to transition to other devices. It's going to take time to make sure that we're not leaving patients behind in this process. And a little bit to that point, Dr. Gay writes, most important, politics is always local. In Minnesota, we have worked directly with local vendors to know their inventory and planned business behavior. Our Rotec vendor is, for example, is already, quote, taking the hit, unquote, and replacing the Trilogy vents in service and not yet failing or needing service. So I think that, and we'll get to, we have some other questions and feedback in the Q&A box also pertaining to what's the right timing for us to be thinking about this as a practice, and I think to be transitioning, and I think that we should consider to be another valuable resource. Karen.
I just quickly want to offer as a resource, I've had a number of labs that as they switch to ResMed have asked for my titration guide and how to do IVAPS titrations and things like that. So please, if anyone needs it, reach out to me and I'm happy to help share some of those resources with other labs.
That's fantastic. Thank you so much, Karen. And then let's move on. I have some questions, and we definitely want to keep hearing. Please write your questions in the Q&A. We'll try to get to as many of those as possible. On the next slide, I have some other questions to pose really to the entire group. What do you think the Philips Respironics most recent announcement, also on the heels of the recall 2 years ago, what does it mean for the practice of sleep medicine in general and also respiratory medicine? Anyone want to take a stab at sort of how the types of pressures that are being applied to our field and our practices and are being translated to our patients, and how that might change our practice in the future?
Well, I think what has been highlighted already, Shannon, if you don't mind me interjecting, is greater collaboration with our surrounding DMEs. I think that comment by Dr. Gay was spot on. And I think one of the things is patients come with a heightened sense of anxiety regarding all of this and a lack of confidence in what this treatment actually means for them long term. Is it going to be more harmful or more helpful based on some of this? And how much more of this are they going to hear? So us being sensitive to those concerns, but really giving them the confidence and working also with our DME providers. They also have to educate their teams in these new technologies, and because they become the responsible provider in many cases on those intermissions between visits. So I think that too is something that we have to help them work alongside and help educate them, as well as them educating us, and really providing the best seamless service we can for our patients.
I just add, I think sleep medicine took a big hit with this. It's already hard to convince a lot of people to use CPAP, and now you've added a whole full of skepticism from a lot of patients that makes it harder. So we need some good studies really showing the long-term benefits of CPAP, things like that are really some firm hard data like the ARC report brought up, are needed to really strengthen our field for what we see every day and improving patients. But the more data, the more good years that go by without these shortages, without these slow ups, without these recalls. I think it'll take a little rebuilding to happen.
Can I ask, I'm curious about a trend. So starting with COVID and with the limitation and shortage of devices, I have noticed a big shift, especially in the mild to moderate patients, but to using oral appliances. So I was going to make the joke of like the dentists are thrilled, right? Because I actually think that there has been not inappropriate shift towards milder patients and increase in the percentage of patients that we're using alternative care for. So my question to everyone on this is, and actually people at home as well, right? Is that my own personal bias, or have you guys noticed that as well, that that's been a little bit more commonly prescribed and we think about that more commonly?
Yeah, I think that was due to the supply chain shortages.
Yeah.
So we're primarily ResMed when the supply chain happened. So then our DME we're a smaller DME, so we didn't get that many, a huge allocation. So communicating with our physicians in our healthcare system, those milder patients, the physicians are going to give them that option, knowing that some form of treatment is better than none.
Yeah, I just want to add, I mean, I've certainly seen that trend, but also and this is more anecdotal, but I feel like, patients have certainly been more open to other options like weight loss and the new weight loss medications. So we've had a pretty good stream of referrals to the, metabolic clinic. And, obviously, I think as these medications have really gotten, more prevalent in the market with more studies showing, but I think the CPAP recall certainly, helped kind of shift some of those patients towards that trajectory. So yeah, I think dental appliance and weight loss has been.
I think you're right. I think it's making us a more comprehensive field, right? And we're thinking more broadly, as we should.
Right. So no practice is an island. Not only do we coordinate more and prospectively with our DME colleagues, but also with colleagues who can provide a more multidisciplinary experience for our patients. And reading through, thank you very much. And continue to, if as other ideas come up, please feel free to comment on them. Reading through the Q&A, a number of questions and comments and feedback around sort of the remaining device marketplace. In particular, some comments around OmniLabs. What are the alternatives to OmniLabs? Are people aware? How are people searching out alternatives, whether it's lab-based equipment or some other devices that might not be have as large of a market share, for example, right now? And also for the panel, what are some of the risks you see of having too few manufacturers of equipment equipment that we really feel is time tested, that we understand, that we know how to use, especially getting under the hood and getting into the details. Lisa brought up an example of that, and Karen brought up an example of that earlier, that these devices are not 100% the same. And it's really important to understand the peccadillos and personalities and settings within the different devices. What are some of the risks or, maybe potentially even benefits of a reduction in the number of manufacturers of devices? So availability is one that's on the slide, but thinking beyond just number of units, I would love to hear some thoughts on that.
I think do you mind out since there's a little quiet going on? This is definitely a competitive marketplace is evolving, which is really great. But I think one of the challenges we met with COVID was consistency and quality. And I think one of the questions is really bringing our regulatory bodies into the mix more firmly in regarding the devices that come out to market, and making sure minimum baseline is provided that we all share as being the quality that needs to be assured by our patients. I don't think we saw that so much during COVID, when some of these newer devices that were coming out weren't quite as ready as they should have been. I think the other thing is, on the flip side, is this definitely adds the opportunity for even better care for our patients when we have a much more robust competitive market, where their technology will probably be shifted more towards the R&D to make things better for our patients, especially with some of the newer data that's coming out on the benefits of using these devices. And then from a final standpoint, again, I would say if we talk about disparity in cost, mild sleep apnea probably is the largest group. If you're shifting over to oral appliances, some of our patients can't afford that. So, that's the other thing, is getting our insurers to take that on, being a little bit more robust in reimbursement to the patients and reducing the cost of that. And I am not a dentist, so my premise for saying that is really kind of, how do we make the bridge happen so patients can be consistently cared for?
And yeah, I would echo the consistency of the devices. It'd be great if we have more, one that people have to say what their protocols actually are for the devices and how they actually are working, and make that more clear. And then more head-to-head comparisons. We have some bench studies, but they also work very differently in live people than we sometimes see in the bench. So a mix of different studies out there really comparing devices, so we can better understand, how they really change. And, we've seen it. Some patients do great when they have a crappy humidifier, and some, need that humidifier. So pushing those insurances, if they get a cheaper device but then don't do well with it, do we have the option to maybe switch them to a different device that might have a better heated tubing system, or some of these sort of more comfort features that not everyone needs, but some people really are helped by?
Yeah, excellent point. And I think this issue around black box and the unique features of each manufacturer's device becomes more complicated when you have newer players in the field, especially when you don't know how big of a commitment you want to make with a particular manufacturer. They don't have the test of time perhaps behind them. I would also direct viewers to another comment in the Q&A from Dr. Gay. We need to plan meetings with business leaders and understand the big picture. What's going to happen to the factory building Respironics devices? Who are going to be the next players? And, listing a number of potentials there. I do think, as a field, we need to stay nimble, and also make sure that as new manufactured devices come online, we really understand the individual features of the device. And as you pointed out, Karen, enable ourselves to be able to view these side by side with one another, so we can understand how the different devices behave. Other thoughts before we move on to our next question? Well, let's do our next slide. Final one here. So We touched on this a little bit earlier, and this is not so much to be. I think a reflection. One learns from history, and so a reflection about the last 2 years and how we've navigated with the recall on the heels of the pandemic is important. But really thinking about, again, getting back to our practice and how we can best situate ourselves to do well by our patients and healthcare. We know that the recall and now the withdrawal of Philips is likely to have some impacts on workloads. We've spoken about that, but there's also the potential for burnout again across our providers in different roles. We're also thinking long-term about the future of our field. What about retention and recruitment of workers in the sleep space, or respiratory space as well? Any reflections from any of the panelists on their work environment? We've heard a little bit about this, sort of the value of planning going forward and making sure resources are available to be able to navigate this. Any additional reflections on that?
I'll go ahead and just kind of give a little background of how things went for us in our clinic. And I know Dr. Doss and I worked together, but we, had to kind of pre-plan that you were going to spend an extra 20, 25 minutes with each of these patients when the recall first came out. Reiterating the importance of education and going through, there was many times in clinic we registered for the patients because they didn't have the availability to do it at home or didn't understand. And so then the extra time with, my chart messages and phone calls and just the concerns that patients had. I remember us nurse practitioners spending at least an extra 20 hours a week just on recall situations alone. And so, as things kind of got remedied and we saw a lot of the solutions happening, patients were getting replacement machines and things were kind of easing up, the workload kind of got better. And then we kind of saw another wave of this getting bad again as, patients weren't getting machines or they were getting offered the compensation instead of a replacement machine. And so it's just been, the 2 years plus that we've been dealing with a lot of this, it still really hasn't slowed down much and different information that comes out to patients, we still have to kind of navigate what we can do for them and try to help out, especially when, the letters are coming out about the financial compensation and things like that too. So it's just, it really took a toll on a lot of us needing a little bit of a break after all this and definitely seeing this kind of going and I've been doing sleep medicine for over 15 years. And so this was definitely one of the biggest impacts I feel like of my career so far. And I was a respiratory therapist before that. And so it's just a lot. And you were talking a little bit about retention and getting, new sleep workers out there. I teach just like Amanda does with respiratory therapy students and trying to get them engaged in DME and get engaged in sleep. Sometimes they hear some of this negative press out there and it doesn't really get them super excited about wanting to go into this field.
And I'd add to that, I think we need to be thinking about our fellows, our trainees. Obviously, they're all operating in this time frame, right? They don't know what it was like before all of this happened. And so we're all sort of growing and evolving, and we don't want to have sort of a negative or pessimistic view of practicing sleep medicine. But I do think we need to be adaptable. And I think it's good we're coming together as a group thinking about things like this, because this is what we're going to have to train our fellows to do too.
One more thing, and I can't claim this, Lisa Wolf and I were talking about this the other day, but something that we need to be thinking of and being aware of and see how it plays out government-wise is who owns all the data that's being held with Respironics, right? We've been caring for patients for decades, and that data is all there. And in 5 years, when the service ends, where's the data go? So I don't have the answer because it hasn't been determined yet, but just to put that out there, so that's one more thing to put on your worry list.
Thank you for those thoughts. And I think, we've already talked about some solutions. A lot of this has to do with reaching across traditional boundaries to think about how do we plan best for the future of the field and for our patients' health. And that might be business leaders and alternative manufacturers. That might be other areas of medicine that provide care that might be relevant for your patients. That might also be working with payers and working at the regulatory level. And This has been a very excellent and really broad discussion. I wanted to open it up for any other solutions that our panelists have been thinking about or have been proposed in their environments. And with just a couple minutes left, maybe we'll hear some of those and then wrap it up here at the top of the hour.
This is Lisa. Shannon, can I just say one other thing real quick? One thing that we haven't really had a chance to touch on is airway clearance issues, specifically cough assist T70. It is important to know that we now have 3 new options in the US. People can use the Voxen, which is the ventilator that does NIV, but also would provide a cough assist in line. In addition, there's the Byways, and there's also from Hillrom, the Synclara. So there are people out there using all 3 of these solutions and having, good luck with all 3. What I would do is get together with your hospital, like Anissa was talking about before, trying not to be too siloed, get together with your RT departments and really proactively try all 3 and decide as an institution how you're going to run forward with those.
Yeah, the only other point I would make is that, the marketplace that we were in before Philips had this issue was not a healthy marketplace. We had 2 major players. One went down, so, it kind of was a recipe for disaster, and that's what we had. In a healthy marketplace, you would have multiple, good, service providers who are all making quality devices. In most of the categories that you need these devices in. And some of it is obviously, private, industry, but some of it is policy, from the FDA and other organizations that regulate to encourage other manufacturers so that the marketplace is not so prohibitive, and difficult to get into, so that other people upstarts are able to come in and make quality devices, because otherwise, we'll have, even if we have 1 or 2 more providers, more manufacturers, one large manufacturer goes down and you get into trouble.
Well, thank you. And I think, these networking, reducing silos, talking together, planning together, reaching across traditional boundaries, that's where we find ourselves. I think we're well equipped to do this, especially with this group of panelists today. I want to thank each and every one of you for taking your time and coming together to speak about these issues. This is the beginning of a conversation. It's not the end of a conversation. I know that ATS and CHEST and the ATS SRN are also planning something as the story evolves and the consent decree is finalized. I look forward to those discussions and to working with all of you and all of our societies to do the best we can as we navigate through this. Thank you so much.
Thank you.